Hi, welcome to everyone. This is our last MEC for this academic year, and I want to first thank all the presenters and also the organizers for this, Carolyn Kling for the molecular endocrinology sessions, and Copper Wintergurst for the pediatric endocrinology. So, as is customary, we have our last presentation by our fellow. Last week we had Dr. Sibai. Today we are going to have Myet Mon Zin, present to us today. So Myet came to us from New York. Like Zach, she is also one of the pandemic fellows. Trained entirely during the pandemic period. Came from a high pandemic to what was a low pandemic and became a higher pandemic area. So she graduated and did her medical school from Myanmar, and she did her residency at Kingsbrook Jewish Medical Center in Brooklyn, New York. And she came here very enthusiastic to learn endocrinology. She had good references, and she actually outdid whatever her recommendations were. So she's done extremely well, both clinically and also academically as a fellow. She's excellent clinician, very enthusiastic, and very thorough. She had two projects that she was working on. One was related to cognitive function and the gut microbiome in individuals with type 2 diabetes and related disorders. And we gave her another project which we had been working on and we had some data on to analyze. And she's going to talk about that particular project, which is related to spinal cord injury. Most of us think of spinal cord injury as a local problem, but that means localized to the spine. But it is a systemic disorder in many ways. So today she will be presenting to us some of the work that she has been able to analyze on spinal cord injury, body composition, and cardiometabolic risk factors.
Thank you so much, Dr. Mock, for your kind introduction. And good afternoon, everyone. Thank you so much for having me here at the Medical Grand Round to talk about this interesting topic, spinal cord injury, body composition, and metabolic risk factor, and their complex association. I have no financial disclosure. And the objective about this topic today is to understand high prevalence of cardiometabolic disorders and identifying cardiometabolic risk factor after the SCI, and to understand metabolic function in individuals with SCI, and to understand body composition change as one of the major factors of cardiometabolic risk factors among SCI patients, and to provide the insight to develop effective strategies to reduce cardiometabolic risks in SCI patients despite knowledge gap. So spinal cord injury is a very devastating and life-changing condition causing paralysis and disability. Not only that, it is also associated with sensory impairment as well as autonomic dysfunction, and it causes a drastic decrease in quality of life as well as decrease in life expectancy. So these are the first figures of spinal cord injury in the USA, according to the 2017 SCI data sheet from NSCIS, the National Spinal Cord Injury Statistical Center. So the prevalence of spinal cord injury is nearly 3,000 people living in the United States. And the incidence is approximately 1,700 new SCI cases every year. And every age of the injury has increased from 29 years during the 1970s to 43 years. And so obviously, male are predominant, male are suffering more from SCI. And when you look at the causes, motor vehicle accident is mostly the cause of the SCI up to like 39.3%, and then followed by falls 31.8%, and then the violence or fights 13.5%. And sports, medical or surgical causes and other causes are 8%, 4.3%, and 3.1% respectively. And according to the neurological level, SCI is differentiated into two injury types. Complete SCI is kind of a complete sensory and motor loss below the site of injury, and at times complete injury results in paralysis. So incomplete injury is there's like a sensory, there's like motor and sensory functions retained below the sites of injury. So when you look at the neurological levels in SCI patient, tetraplegia, patients are suffering mostly from the tetraplegia. So incomplete tetraplegia is up to 47.6%, and then followed by incomplete paraplegia, 19.9%, and then complete paraplegia, 19.6%, and complete tetraplegia, 12.3%. And there's no, there are also like small portions, 0.6%, with no neurological deficits. So you can see from the slides here that SCI has been a huge healthcare burden. So when you look at this estimated lifetime cost by the SCI, it's like $1 million money, especially in the younger patient. For the 25-year-old patient, high tetraplegia patient will cost lifetime expense like $5 million. And 1/5 of the amount is like in the first year of the injury. And in the subsequent year, it will decline to like $100,000, but it is still very pricey. And the cost is a little bit reduced in the elderly population around 50 years old. So the mortality is the highest during the first year after the SCI, especially during the initial hospitalization. The mortality rate is up to like 5.7 to 8.0%, and after the initial hospitalization to at the end of the first year post-injury, it declines to 4.6%, but it stays pretty high. And the most common problem leading to the mortality at all time is respiratory disease, up to 31% during the first initial year. And non-hypertensive, and especially because of autonomic dysreflexia and non-ischemic heart disease, up to like 13.8%. So from second year onwards up to 30 years post-injury, the mortality declined to 1.7 to 3.0%. Still, respiratory disease is a very high cause leading to high mortality, and followed by infection, cancer, hypertensive, and ischemic heart diseases. So the cardiovascular concern in spinal cord injury. There have been like a higher prevalence of cardiovascular disease, leading to greater morbidity and mortality from cardiovascular causes. Also, it is related to the increase in lifespan of the SCI and aging process. So the most important cardiovascular risk factors in SCI are low HDL cholesterol, high total cholesterol, and low high total cholesterol and LDL, elevated C-reactive protein, high prevalence of obesity, and greater visceral adipose tissue. These are the changes happen after the SCI, and increased proportion of body fat due to the loss of fat-free mass, and the increased rate of smoking, physical inactivity, higher prevalence of insulin resistance, diabetes, and metabolic syndrome. And the other factors, the other concern about the cardiovascular risks in the SCI patients are blood pressure abnormality, orthostatic hypotension, autonomic dysreflexia leading to hypertensive urgency, and deep vein thrombosis and thromboembolic events, and rhythm disturbances, especially bradyarrhythmia during the acute phase, reduced heart rate variability, blunted cardiovascular response to exercise. So we'll be focusing on these highlighted risk factors: higher prevalence of obesity and greater visceral adiposity, increased proportion of body fat due to loss of fat-free mass, and leading to insulin-resistant diabetes and metabolic syndrome today. So this is an article published in Spine Journal in 2021, and this article is about research, a longitudinal cohort research, and the background context is individuals living with the SCI are at a heightened risk for a number of chronic health conditions such as secondary comorbidities that may develop or influenced by the injury, the presence of impairment, and or the process of aging. The purpose of this study is to compare the incident and adjusted hazard for the cardiometabolic morbidities among adults following SCI compared to the adults without SCI. And so there are 9,000 patients, traumatic SCI patients enrolled for this study, and 1 million patients enrolled without SCI as a control. And incident estimates of common cardiometabolic morbidity were compared at the full year of enrollment, and survival models were used to quantify and adjusted hazard ratio for incident cardiometabolic comorbidities. So what they find out is SCI patients, traumatic SCI patient has a higher 5-year incidence of any cardiometabolic morbidities, 56.2% versus 36.4%, and compared to the control patient population. And also, when you look at the hazard ratio, the greater hazard ratio for the traumatic SCI patient population for any cardiometabolic morbidity, hazard ratio 1.67, and all cardiometabolic disorders, hazard ratio 1.45, and for non-alcoholic fatty liver disease, hazard ratio 3.55, when compared to control population. So they concluded as like adults with SCI have a significantly higher incidence and risk of common cardiometabolic comorbidities as compared to the adults without SCI. So efforts are needed to facilitate the development of improved clinical screening algorithms and early intervention to reduce risks of cardiometabolic disease onset and progression in this vulnerable SCI patient population. So this is the graph they have shown in the article, and you can see clearly the case. This is a Kaplan-Meier curve, and the plotted Kaplan-Meier curve, survival curve for the SCI patient is much reduced than the control patient population. Also, this is an article published in the Journal of Neurotrauma, and this also illustrates the tragedy defining the age-related increase in cardiovascular disease risks is likely increase after the spinal cord injury, which is the result of a number of interacting factors such as increased adiposity and obesity, glucose intolerance, vascular dysfunction, reduced physical activity, chronic inflammation, as well as other factors. So this is the graph illustrating how spinal cord injury leads to cardiovascular disease. After the spinal cord injury, patient become disabled and paralysis, and which leads to sedentary lifestyle, and the patient became overweight and higher body fat content, and finally leads to glycemic dysregulation and dyslipidemia, and cardiovascular disease happen later. And spinal cord injury is a chronic inflammation, systemic chronic inflammation, which is also the contributing factor to the cardiovascular disease. And also autonomic dysfunction comes after the spinal cord injury, blood pressure irregularities, alter cardiac electrophysiology, arrhythmias, finally leading to cardiovascular disease. And as you see in the picture, the impulses for the cardiac angina pain ascend from C1 to T5 region. So this sympathetic and vagus nerve go through this region. And when the cardiovascular disease comes, the cardiac angina pain cannot manifest in most of the SCI patients because the cardiac symptomatic import is interrupted, especially in high thoracic and cervical SCI patient above T5 level. So they can present with an atypical presentation, and which leads to delay or misdiagnosis, and they can even present with drop dead. So this is a very interesting article published in 2007 in Spinal Cord Journal, and this is about the skeletal muscle atrophy and increased intramuscular fat after incomplete spinal cord injury. This is a cross-sectional and longitudinal design, and to quantify the skeletal muscle cross-sectional area after correction for the intramuscular fat in thigh muscle groups 6 weeks after the incomplete SCI patient, and to monitor the changes in the muscle cross-sectional area and intramuscular fat portion after 3 months from the initial assessment. And there were six incomplete SCI patients enrolled, and the average age is 28 years, and there are 6 able body control enrolled in this study. They are age, sex, and height and weight match. So they found out at 6 weeks post-injury, during the first initial assessment, muscle cross-sectional area was 82 plus or minus 4 centimeters square in incomplete SCI, and in able body control is 123 plus or minus 21 centimeters square. So the relative intramuscular fat was also 3-fold higher in SCI group versus able body control. After the 3 months, intramuscular fat increased 26% in SCI group itself in comparison to the initial assessment, which is 6 weeks after the post-injury. And they concluded as skeletal muscle atrophy is associated with greater intramuscular fat accumulation in SCI group 6 weeks post-injury compared to able body control. Moreover, intramuscular fat continues to increase over time in incomplete SCI patients. So this is a T1 weighted MRI of the mid-thigh in figure for the able body control patient, and the lower figure showing the incomplete SCI patient 6 weeks after post-injury. So this is the initial assessment MRI pictures. So you will see the difference in the muscle size, the cross-sectional area, and between the 2 groups, and also you will see like intramuscular fat infiltrated within the left thigh muscle groups. And although they didn't mention about that, you will see a generalized fat distribution here is more than the control body, able body population. So it was also found out, according to the analysis, comprising 40 studies and including 4,800 individual SCI patients, that body composition changes also depend on the level of injury. So what they found out during this meta-analysis is cervical level injury tetraplegic patient had a higher total body fat percentage, visceral obesity, but lower leg fat mass compared to the paraplegic patients. So all the collective research and data has suggested that there is skeletal muscle atrophy, intramuscular fat accumulation below the injury occurs acutely, and later higher body fat content comes. And this body composition changes develop rapidly after the injury. And the loss of metabolically active skeletal muscle, this skeletal muscle atrophy leads to the decreased basal metabolic rate and then resting energy expenditure. And due to the intramuscular fat accumulation, extra or intramyocellular lipid accumulation, which is known to cause the fat in the insulin signaling and reduce insulin stimulated skeletal muscle uptake, so which finally leads to impaired glucose metabolism and dyslipidemia. Also, in individual with chronic SCI, they have sedentary lifestyle and poor compliance with the dietary recommendation, which finally leads to positive energy balance and fat accumulation and obesity. So it is interesting that an individual with SCI, not only they are experiencing dramatic muscle loss, but also experiencing bone changes. So this bone loss osteoporosis is also one of the factors contributing to loss of fat-free mass and finally leading to cardiometabolic risks. And osteoporosis is a well-known complication after the SCI. As we know, it is characterized by low bone mass and skeletal microarchitecture deterioration, resulting in decreased bone strength and increased risk fracture. And this picture shows that the cortical bone, the cortex layer is shrinking and thinning. And in the trabecular bone, there's like loosening fine connections and fewer and thinner trabeculae. So this bone resorption in SCI happens as early as few days after the SCI, and the rapid decline in bone density mainly happen in the first 12 to 8 months, and also it continues for several years. The unique pattern about the SCI and osteoporosis is self-lesional, excessive bone resorption below the level of injury, and low bone mineral density of the hip. Low bone mineral density mainly happen around the hip and knee regions. And lumbar spine is interestingly maintains normal or higher bone mineral density after the SCI. And now weight-bearing lower extremity don't have this stimulation, and therefore low bone density happen mainly in the lower extremities. The most common fracture site is around the knee, distal femur, or proximal tibia specifically. An increased risk of fracturing the bone at the same place can also happen even after the fracture heals. Bone loss is seen more prominent in complete SCI patients than incomplete SCI patients. So which lead to osteoporosis after the SCI? They are multifactorial and very complex pathway mechanisms, and non-mechanical factors are important, and then insufficient nutritional support, disorder visual regulation, and hypercorticolism state due to the stress or due to the steroid usage in the SCI patient, especially immediately after the injury, and alteration in the gonadal function. It is also believed that SCI patient, especially the male population, have a lower testosterone level, and other endocrine disorders. And other influential factors on the bone mass in SCI is muscle loading on the bones and level of the lesion, extent of the functional impairment, duration of the injury, and aging. So these adverse body composition changes, intramuscular fat infiltration, and central obesity, increase in fat deposits, and bone changes in the SCI negatively impact the body metabolism, and that finally increase the risk of microvascular diseases. Also, gut dysbiosis happen in SCI patients. As we all know, gut microbacteria has a lot to do in our body physiologically, and also it is a very influential and important factor on various disease processes. So as you see here in this illustration, gut microbiota has multiple effects on the body, and associated with irritable bowel syndrome, obesity, psychiatric and neurodegenerative disorder, stroke, pain, seizure, addiction, cognitive and social behavior, such as stress, fear, and food intake. So gut dysbiosis is commonly defined as depletion of beneficial non-pathogenic gut bacteria and coincidental increase in pathogenic bacteria, as you can see in this picture. And after the SCI, gut dysbiosis has been documented in multiple clinical and preclinical studies, especially in the animal models. And after the SCI imbalance of, the important thing is like until this date, we still don't know what is the exact mechanism or pathway leading to gut dysbiosis and SCI. This is a presumed mechanism in SCI patient leading to gut dysbiosis. After the SCI imbalance in the autonomic tone and cause an impairment in gut motility, mucosa secretion, vascular tone, and immune function, which leads to impaired transit and incontinence and constipation, finally leading to change in bacterial composition in the gut. So these are the two animal models that have been done to show the gut dysbiosis in SCI animals. So after the SCI, there's a loss of central nervous system control over GI tract, and neurological bowel dysfunction happens, and alter colonic transit time finally leads to gut dysbiosis. And gut dysbiosis also has a loop feedback on the spinal cord injury. So after the gut dysbiosis, increased interstitial permeability, leaky gut happens, and bacteria translocate from the gut to the distal organs. So not only local or regional, which mean intestinal inflammatory process occurring, but also systemic inflammation occurs because of the bacteria translocation. So which finally caused neurological recovery, delay in neurological recovery because of aggravated lesion pathology, and also accelerated development of metabolic and secondary health condition, including the obesity. And as you have seen in this picture, the gut microbiota has also had control on the food intake. So after gut dysbiosis, with the disrupted food intake pathway, and it also leads to the obesity. So this is an article. This is the very first article about the comparison of the gut microbiome composition among the individuals with the acute, which I mean the first article is acute in acute spinal cord injury or long-term spinal cord injury versus able body controls. So this is a cross-sectional study. 7 adults with acute spinal cord injury and 25 with a long-term, long-standing spinal cord injury are enrolled in this study, and 25 able body controls are participated in this study. And they use a 16S RNA sequencing to know the gut microbiome composition. And what they found out was there are these bacteria which are well known to be associated with elevated serum glucose level, lipid concentration, and leading to impaired glucose and lipid metabolism disturbance, are higher in the chronic SCI patient as well as in acute SCI patient population than the able body control patient population. Not only that, in SCI groups, both acute and chronic SCI group, they found out the bacteria families which is shown to be higher in the inflammatory bowel disease, colorectal cancer, immunogenic diseases, and also associated with the inflammatory bowel disease. So they concluded that the differences in gut microbiome composition among the groups has revealed according to their results. And compared to the able body control, SCI group demonstrated a microbiome profile that share features linked to the metabolic syndrome, inflammation-related bowel disorder, depressive disorder, and antibiotic use. And also in chronic SCI patient, microbiome-induced microbiome features are linked to the reduced physical activity. And gut microbiota represent a very important biological variable that is significantly affecting the health, recovery, and well-being of the SCI individuals, yet we say are not clear about the causal relation, precisely how gut dysbiosis develop after the SCI. And also limited research about the gut microbiome composition in the human model. And whether it persists indefinitely stay unknown. and functional consequences of the SCI-induced dysbiosis, how it affects on the structure as well as in the function of the CNS and other body organs are still unknown. And age, sex, level of a reduction in physical activity or exercise, increase physiological stress, psychological stress, and antibiotic usage. All these factors are still to be to be understood, like how this influence over the SCI-induced gut dysbiosis. So this is a research disciplinary university-wide collaborative program on medical research for the SCI at the University of Louisville. It is happening. So this is an interdisciplinary research with a clinician and business scientists collaborating and integrating their faculty, staff, trainees, and leveraging course resources and expertise. And signature and pilot projects directed at specific medical problems with parallel human and animal experiments to understand underlying biological mechanisms and progress novel treatments. So signature project 1 is about cardiovascular, pulmonary, and autonomic dysfunction after the SCI, and signature project 2 is about the metabolic syndrome and SCI. So funding comes from Council Charitable Trust, and principal investigators are Dr. Susan Hakimer, Max Boaki, Scott Whitemore, Dr. Craig McLean, and Dr. Shivave. So I'll present some of the data from the microbiome syndrome, metabolic syndrome, and SCI project, signature project 2. So this is what I have explained earlier, like how SCI patient develop to metabolic disorders. After the SCI, alter body composition, decreased lean mass, increased fat mass, fat infiltration in the muscles and visceral sites, which cause glucose intolerance, insulin resistance, and lipid abnormalities leading to comorbidities, chronic CNS inflammation, metabolic disorders, type 2 diabetes, and cardiovascular diseases. So in this sequence, gut microbiome has a huge role participating. After the SCI gut dysbiosis and permeability happened, and then because of the microbial translocation, endotoxemia and inflammation comes, finally leading to these chronic comorbidities. So we are interested in therapeutic interventions, electrical stimulation, locomotor training, probiotics, exercise, diet, and novel drugs, how these has an effect on the changing comorbidities in SCI patient, and we are doing this research. So this is how we measure the disease process in this trial. And for the glucose metabolism and insulin resistance, we use A1C HOMA glucose tolerance test, insulin and lipid profile. For the immune function and suppression, we use CRP, plasma cytokines, and FACS, flow cytometry analysis of inflammatory cell, quantitative PCR for the inflammatory markers and cells. So for the oxidative and acute autopathy stress and endoplasmic reticulum stress, we are using isoprostanes, acrolein, TBARs, SAA, antioxidant capacity, qPCR for the ER stress and autophagic genes. And for the gut barrier function, lipopolysaccharides, soluble CD14, IFA BP, calprotectin microbiome we are using. And for the body composition, we are using DEXA scan and a BOD pot. And for the GI function, gastric emptying, autonomic function, and capsule study we are using. And for the figure study, metagenomic and metabolomic profile we are using to analyze gut dysbiosis or bacterial composition. And for the liver function test, ALT, AST, GGT, albumin, bilirubin, CK18 are measured. And for the clotting process, fibrinogen, PAI1, PF4 are measured. And for endothelial cell function, ICAM1, endothelin, HAE selectin, occlutin, and zonular occludins 1 factors are measured. And for biomarkers, and serum and urine stool sample are selected proteomics and metabolomics. So this is a DASA scan measure. We can basically measure the whole body fat with a DASA scan, the trunk region, leg region, arm region, and head region. So this is open CM, and then the ray coming from this source. Basically, it is the same as a DASA scan and bone density measurement. Just they need to change certain and parameters to measure to measure the body fat composition. So this is a board pot. It is a computerized egg-shaped device that measures the body weight and volume to know body density and calculate the percentage of the body fat. Claustrophobic patients are not suitable for this board pot measurement. So for the measures of glucose tolerance and insulin resistance, as I mentioned, we use our glucose tolerance test with a 75 gram glucose loading, and blood samples are drawn for the glucose and insulin at 0, 30 minutes, 60 minutes, and 60 minutes, 90 minutes, and 120 minutes respectively. And we use the ADA criteria for the normal, impaired fasting glucose, impaired glucose tolerance, and diabetes. And insulin resistance was estimated using the following HOMA2, HOMA-IR, and Masuda index. Insulin secretion was also estimated using the insulinogenic index and also deposition index, which is known as a more reliable to predict the glucose intolerance and the future development of the type 2 diabetes. So these are the demographics for the patient. There are total 62 patients. The mean age is 34.4, pretty young. And body BMI, as you see here, the mean body weight is 23.8. According to the normal population cutoff, they are not even in overweight or obese kind of cut point. And more male, 43 patient, and female is 19 patient enrolled. And injury years is average is 7.4 years. More cervical injury patients are in this study, and more of the AIS score is in this study. So the main BMI, as we have talked, like a 28.3 plus or minus 5, with 64% having BMI less than 25 and 11% more than 30. And mean A1C, as you see, normal A1C 5.0% in 95% of patients, and less than 5.7. So the mean is 5.0. 95% is 95% of the patient population A1C is less than 5.7. So as you see in this outcome table, low HDL cholesterol was noted in 47% of individual, and high triglyceride in 22% of SCI patients. And total and percent, this is a correlation graph that I shown here, and total and percent trunk fat. Here, as you see, positively correlated with a p-value less than 0.05 with triglyceride and non-HDL cholesterol. These are the positive correlation here. And impaired fasting glucose was noted in 15% of the individual with SCI, and abnormal glucose tolerance was noted in 32% of individual with SCI. Total and trunk fat are correlated positively with the glucose at 30, 60, and 120 minutes during OGTT tests, as you see here. And HOMA insulin resistant and body composition, HOMA-IR was more than 2 in 37% of individual, and Masuda index was less than 4.3 in 57% of individual with SCI. Total and trunk fat correlated positively with HOMA-IR and negatively correlated with Masuda index, as you see here. And regarding the inflammatory markers, HSCRP, a global measurement of chronic systemic inflammation, we see is higher in individuals with SCI. HSCRP also correlated positively with the total and trans fat. And among other markers of inflammation that I didn't show here as a figure, interferon, gamma, interleukins, macrocyte, macrophage inflammatory protein, monocyte chemoattractive protein. Among all those inflammatory markers we tested, only interleukin 8 and MIP1B, MCP1 show positive correlation with total and transglyceride mass. And we still don't know what behind this association. So we concluded as this cardiometabolic risk factors are highly prevalent in this group of young individual with chronic SCI. Despite a relatively normal BMI 23 in most of the patients, total trans fat appeared to be a major factor associated with these abnormalities. So this pathway leading to this association is still unclear. And the association of limb mass with certain cytokine still needs to do further exploration. And the impact of interventions such as diet, exercise, aimed at the changing body composition, visual stimulation, and use of probiotics are among interventions that are being studied. And also gut microbiome data. We have a large pool of data, but we are still in the process of analyzing and interpreting those data. So I didn't put it here. So this guideline for the clinicians and healthcare providers developed in 2018, identification and management of cardiometabolic risks after the spinal cord injury. It came in 2018. So the guideline says that the definition of the cardiometabolic disease in SCI patient is the same as in general population. The according to the American Heart Association and HLBI, the definition is still lacking a fully harmonized criteria, but the co-occurrence of any three of these metabolic risk factors described in the table, it is called cardiometabolic disease CMD. So what are those factors? The waist circumference, as we know, men greater than 40 inches, waist circumference, and women greater than 35 inches, and plasma triglyceride more than or equal 150 milligram per deciliter, low HDL cholesterol in men less than 40 and in women less than 50, and elevated blood pressure more than 130 by 85 milligram mercury, and fasting blood glucose more than or equal 100 milligram per deciliter. So any three of those 5 factors we call cardiometabolic disease. And it is a health equivalent to diabetes mellitus and atherosclerotic disease. So what they recommend in the guideline is like to evaluate all the adults with the SCI for cardiometabolic disease, all the adults. And at the time of diagnosis, at the time of discharge from the rehabilitation, as early as possible. And if we miss to do cardiometabolic disease assessment during the rehabilitation time, we should do as early as opportunity as possible. And obesity and SCI, they recommended like to use these cutoff. Still, there are data limited, which is leading to like to use this cutoff. But whatever available data, this cutoff, this is what they are suggested to use in SCI patient to define the SCI, to define the obesity. So in adult men, to use body fat more than 22% and adult women more than 35% as obese, and if possible, measure the body composition using 3 or 4 compartment models to report the obesity in adults, such as MRI, CT, DEXA scan, ultrasound, and stuff like that. And BMI, if we want to use as a BMI as a obesity, and then we should use a cutoff 22 kilogram per meter square in SCI patients. And at least every 3 years following the initial assessment should be done, obesity, to do the obesity assessment should be done in normal and asymptomatic patients. And as a pharmacotherapy treatment, the prescription medication that are approved in the normal population, it is still not recommended in SCI patient. So if the clinician wants to use those FDA-approved medication in the SCI patient, it is up to the clinician. It should be individualized. And of course, nutraceuticals over the counter and have immunogenicity, diuretics, nutrient uptake inhibitors for the body fat and mass reduction is totally not recommended. And as a bariatric surgery to control the obesity is only should be considered as a last resort in patients with severe obesity. So for the impaired fasting glucose, prediabetes, and diabetes patient in SCI, the guideline adopts the American Diabetes Association guideline as in able-bodied patients, and they recommend to repeat the testing at least every 3 years if tests are normal. If we have to use the pharmacotherapy, metformin is the medication that they recommended above if HbA1c is above 7%. And we should also consider specific criteria when we are selecting the hypoglycemic agents, which may provoke hypoglycemia, resting and posterior hypotension, lymphedema, heart failure, and urinary tract infections. And to consider referral to the endocrinologist. And for the dyslipidemia, it's also the same like as a general regular normal population to monitor the fasting lipid profile, LDL, triglycerides, HDL, and non-HDL cholesterol, and it should be repeated every 3 years if it is normal and asymptomatic during the initial assessment, and to perform in your annual screening if the patient has multiple cardiometabolic risk factors and dyslipidemia, if we find dyslipidemia, or if the patient needs treatment. And the pharmacotherapy-wise, potential and recognition of the cardiovascular risk in the SCI patients. So they recommend like to use a low level of HDL-C and high level of C-reactive protein to guide the patient selection to start on the pharmacotherapy. Although they didn't say specific numbers, what to look at and stuff like that. So basically it is dependent on the clinician decision. And to initiate monotherapy, firstly, using at least moderate intensity statin, for example, rosuvastatin 10 to 20 milligram per day. And lifestyle intervention is very important in SCI in the patient population. Calorie assessment should be done regularly by using indirect calorimetry to estimate the energy expenditure and to assess the energy needs. And as a diet, a guideline recommend like a multiple diet plan, the healthy nutrition plan, rather than following the single diet plan. So they recommend DASH diet and Mediterranean nutrition plan in SCI patient population. And to also limit the saturated fat to 5 to 6% of the total calorie intake, and to limit the daily sodium intake to less than 2,400 milligram. And physical activity, at least 150 minutes in a week, the SCI patient should be doing exercise according to, of course, it also depends on their ability, and it should be studying as soon as possible after the injury. So these are the goals management for the cardiometabolic disease in SCI patient. For the CMD diagnosis, reduce the number of the risk component to less than 3. And obese or overweight patient reduce their fat mass to achieve a BMI less than or equal 22. And for the insulin-resistant patient, reduce their fasting blood glucose less than 100 milligram per deciliter. And A1C is a little liberal, less than 7%. And dyslipidemia to reduce the triglyceride to less than 150 milligram per deciliter. And increase the HDL cholesterol to above 40 in male and above 50 in female. And hypertension to reduce blood pressure, systolic blood pressure to less than 130 and diastolic to less than 85. So as we know, SCI results in multiple abnormality that affect a wide variety of cells, organ, physiological system that have the complex interaction resulting in increased cardiometabolic risks leading to cardiovascular events and mortality. So the care of the individual in SCI requires multidisciplinary efforts. So the future directions we get from trying to understand cardiometabolic risks and cardiometabolic disease in SCI patient and their comorbidity, mortality, and morbidity. We have these future directions, and to explore more about the mechanism that could explain body fat distribution changes and visceral obesity, as well as phenomenon and pathways that could explain gut dysbiosis in SCI patients, to develop preventive measures and early interventions such as diet, probiotic, exercise, visual stimulations, and longitudinal studies and randomized controlled trials to define the cause of cardiometabolic disease in SCI patients and the effect of different interventions, and to refine the guidelines and screening and management improvements, and to disseminate all those knowledge and guidelines to generalists as well as SCI provider, as generalists often lacks SCI specific knowledge, and also only few SCI providers are keeping up with the SCI related cardiometabolic literature. So I would like to say thanks to all those amazing people, Dr. Susan Hakima, Dr. Boaki, Dr. Diaz, Dr. Rejek, Dr. Angeli, and Mr. Wang, and Dr. McLean, Dr. Vabe, Dr. Gobi Jashivi, and Dr. Moksha Gandam, who is also my great mentor, who let me participate in these amazing and interesting clinical trials. And so this is about my presentation, and I'll be answering whatever question you have. Oh, today's code is 1281835. How do I do that?
Wasn't it the last slide?
No.
You can put it in the chat.
No, it's not coming. I don't know.
Where is your? Are you seeing the screen? Zoom.
Why is not coming?
Remove the rest of the
Oh, I don't know. It is not sharing. I can type in there. 2811835. Should I type? I'm trying to share, but it's not happening. I don't know why.
No, it's not sharing.
Yeah. Yeah, I don't know why.
So you have some questions here.
Yeah. I should stop sharing, right?
Mm-hmm. So you have to tell the. You have some questions there, correct?
Yeah. Mm-hmm. So the first question is, what is the current early intervention following SCI that can have better outcomes? So the early interventions, as I explained in the guideline, like in 2018 guidelines, like diet modification and exercise, and to reduce the cardiometabolic risk factor to lower than 3 factors. So these are the things we can start with. And the next question, any insight on new therapies like a direct injection of therapeutics or stem cells in the injured region of spinal cord? How about testing for complement components as markers for inflammation following SCI? So I believe there is an animal research model happening in University of Louisville, even in University of Louisville, testing about those direct injection of therapeutic and stem cells. Yeah. So, but I'll not be able. I honestly don't know about the complement component as a marker of inflammation following the SCI. Have you considered applying for KSCHIRT funding for your future research? The deadline is August. Thanks for graduating. Okay, I'm leaving the University of Louisville. So, Dr. Mock, are you considering to apply for future research, the funding? And muscle fat generates cytokines known as myokines that might contribute to insulin resistance. Does lower extremity exercise reduce lower extremity muscle fat? Yes, yes. And there are also a lot of articles and also ongoing research, like to what extent and how long that kind of effect will last, and to what extent that effect will have. There are still a lot of research ongoing and also have done in both animal and human research models. Thank you, Dr. Folsom.
Questions here?
So any questions? Yes.
You mentioned that usually metformin is usually the preferred agent used for patients with diabetes. Is that just because for all patients with diabetes, or specifically with patients with spinal cord injury?
Exactly. Yes. Yes. Yeah. So Dr. Sabine's question is like why the metformin is recommended specifically in SCI population. So metformin is also the first line drug in regular population. Also the same in SCI population, especially because there are also research done and also ongoing research that metformin has good effect on the gut dysbiosis. Good question. Thank you. So any question? So thank you so much, everyone, again, for having me here and to talk about this topic. Thank you. Have a great evening.